Dr. Aurora?
Hi, my name is Sanjeev Arora, and I serve as the director of the Echo Institute. And it's a great honor and privilege to have Dr. Swamya Swaminathan with us today. And I also want to welcome you all to the Global Conversation series, to this really important topic about what is the science of COVID-19. And of course, Dr. Swaminathan will take all your questions. Over to you.
Wonderful. Thank you, Dr. Aurora. Exciting announcement here. We've just learned that we also have French interpretation services available as well. So same process for activating the interpreter services. Click on the interpretation icon in the bottom, and you can click on either Spanish or French. So thank you very much for the support of our interpreter services. A couple of housekeeping items before we get started. Because of the large number of participants joining us today, we will have all of our participants in listen-only mode for this session. And then we'll ask that rather than using the chat function at the bottom of the screen, if you can please submit any of your questions under the Q&A function at the bottom. And we will field your questions. We did receive over 350 questions, so we apologize in advance that we likely won't be able to get to all of the questions today. We are going to also ask that you please refrain from answering questions in the Q&A. And that said, definitely keep an eye on the chat function at the bottom, because you're going to see a number of resource links in the chat function from our Echo Digital Librarian. And at the end of today's session, we'll also be posting a link in the chat box that you can click on to obtain your CME and your CEU credits. Your feedback is important to us, and we appreciate all of you completing that session evaluation. And then please allow 48 hours for this session to be recorded and available for download. And for those of you who were not able to join us for the recently conducted telehealth mini-series, those are now available, and you can download those and watch them. And we're going to post links to that in the chat as well. And so without further ado, it is an honor to introduce our speaker today, who is Dr. Soumya Swaminathan, Chief Scientist of the World Health Organization. Dr. Swaminathan is an Indian pediatrician and clinical scientist globally recognized for her 30 years of experience and research on tuberculosis and HIV. She has been Chief Scientist of the World Health Organization since March 2019. Previously, she served as Deputy Director General of Programs at the World Health Organization, the Secretary to the Government of India for Health Research, Director General of the Indian Council of Medical Research, and is coordinator of the UNICEF UNDP World Bank World Health Organization Special Program for Research and Training in Tropical Diseases in Geneva. Dr. Swaminathan received her academic training in India, the United Kingdom of Great Britain and Northern Ireland, and the United States of America. She has published more than 350 peer-reviewed publications and book chapters. She's an elected foreign fellow of the U.S. National Academy of Medicine and a fellow of all 3 science academies in India. She has served on many global advisory bodies and commissions, including the World Health Organization Expert Panel to review global strategy and plan of action on public health, innovation and intellectual property, the Strategic and Technical Advisory Group of the Global TB Department at the World Health Organization, and most recently was co-chair of the Lancet Commission on TB. And today, Dr. Swaminathan will be presenting COVID-19, What the Science Tells Us. So thank you very much, Dr. Swaminathan. We'll hand it off to you, and you can share your slides.
Thank you very much, Matt and Sanjeev. I hope you can hear me okay. Thanks for this opportunity to speak to your global network, and also for the introduction. And I'm sure that there'll be many more questions at the end of this session that we all need to collectively answer. So I don't promise all the answers, because the science is evolving all the time. Let me go into slideshow mode, and do you see the slides?
We see your desktop right now, but we don't see the slide.
Well, if I go here,
You have your PowerPoint open?
My PowerPoint is open.
Okay, just click a share screen in the middle.
But it's not in slideshow mode.
It doesn't matter. I think we can see it quite well. We can just go, yeah.
Okay, will this work?
Yep, it'll work.
Okay, sorry, I don't know. It worked before, but. So, okay, so let me get into it now. I'm going to run through a lot of different topics, and I'm going to do it quite fast because I know that we're going to have time for question, answers, and discussion. Let me start with some global epidemiology. I'm sure all of you see the numbers all the time in the media, but as you know, we are now over 7.5 million with over about almost getting to 450,000 deaths. And what's going on now is that the epicenter really is in the Americas, with growing numbers in South Asia and in Africa. And you can see the darker colors here are the countries that are representing the highest numbers over the last week. And this graph actually shows you by WHO region. So the WHO has 6 regions. And what you can see here is that it was, the orange is Europe. And so the Europe, the disease has already peaked and you can see it's coming down, whereas you see the Americas is still going up. The purple is the Eastern Mediterranean region, so particularly Iran, Pakistan, and Saudi Arabia. In the Americas, apart from the US, it's Brazil, Peru, Ecuador, Chile, and some of the smaller countries as well. You can see Southeast Asia region is a small in terms of the number of countries, but it's India, huge population, Indonesia, Bangladesh, which are the 3 countries really contributing here. And in fact, the Western Pacific region, which is the light orange, in fact, is the best. You see this little peak at the beginning, which was China, but then after that, they really got it well under control compared to the others. And then the little blue on top is Africa, which is slowly growing and which is a very worrying region for us because of many reasons, including the poor or the weak health system capacities. And if it really takes off, the strain that it would put on health systems. Now, if you look at, we get reports submitted to us, and this is the figure that shows the distribution of cases here, confirmed cases. This is, these are males and these are females. And you can see that the majority of the cases are in the middle age group from about 20 to about 60 or 65. More women in the oldest age group, perhaps that's because of the differing lifespan, longevity in between men and women. And again, you can see the deaths more among males, adult males, than among females, except in the highest age group. And luckily, and fortunately, very low death in the below 20 years age group. So just to be clear, I'm sure again everyone is aware that SARS-CoV-2 is the name of the virus. It can be found in people who are asymptomatic or what we call pre-symptomatic. So you can have virus isolated 1 to 3 days before developing symptoms, then symptomatic and post-symptomatic. The disease is referred to as COVID-19. And just for interest, this name is given by WHO under the ICD-11. This was agreed a few years ago that WHO would name new diseases, and there was an agreement also on the principles and criteria that would be followed so as not to stigmatize places or people when you name a disease after that place. And this is named by the International Virology Association, and they go by the phylogeny of the virus and looking at the sequence to see where best it fits. And obviously it fits within coronaviruses, but is very close to SARS-CoV-1 in terms of the genomics. And that's why the name of the virus and the name of the disease are different and are also given by different groups of people. How does it get transmitted? As best as we know, it's mostly transmitted by droplet infection. Droplets, of course, come out when we cough or sneeze or even breathe heavily or speak. They're of varying sizes. Larger droplets, which tend to settle to the ground. The smaller droplets are what we call the aerosolized particles, which can last longer. But most of the droplets are greater than 5 microns, and they drop to the ground within about a meter distance. And this is where the 1 meter, minimum 1 meter distance between people comes up. Then, of course, there is a possibility that the virus can stay on fomites, that the droplets fall on fomites and it can survive for some period of time, and then it could be transmitted by the hand. So person to person is the predominant mode of transmission. As so far, there's no conclusive evidence of vertical transmission, though there have been reports of newborns actually now getting infected. So again, the science keeps changing, but whether it's vertical or whether it's soon after birth is still to be determined. And the peak infectiousness is during the pre-symptomatic and the early infectious period. Now, again, we know symptoms appear anytime between 2 to 14 days after exposure to the virus. And we are also learning more about symptoms. We knew there was cough, fever, fatigue, fever, chills, body aches, but also the loss of smell and the loss of taste seems to be quite a prominent symptom, which was not reported originally from the Chinese cohorts, but started getting reported from the European cohorts. So again, we don't know exactly why, but we do know that the virus attaches itself to receptors, the ACE2 receptors, etc., which are present in the nasal epithelium. And it can also cause headaches, of course, shortness of breath. You may not have fever or cough, could present just with shortness of breath, gastrointestinal symptoms, and also skin manifestations. There are people reporting the vascular lesions or the toes and fingers like a chilblain-like presentation. And then, of course, we know that in children, you have something which is now being called, it was being called Kawasaki-like, but we now have a name for it. It's a multi-inflammatory syndrome in children. It presents usually a few weeks after the child has had almost asymptomatic infection. The serology may be positive. The viral test is usually negative, and it's a vasculitis which affects multiple organs, can present like a septic shock syndrome. It can also present like a myocarditis. It could present with a gastrointestinal manifestations. So we're still collecting more information and data. It's not clear whether there's a genetic predisposition to this or whether it's some anomalous immune response, but it's important really to understand more about the pathogenesis. So the clinical presentation in different cohorts has been a little different. As I said, from China were the original descriptions, but then more descriptions coming in from Europe and now from the US and other parts of the world. I think we've gone through what these mean. Now, the risk groups for severe disease and death, obviously we know are some of these conditions. The older the age group, the more the risk. Smoking is a risk, as is all of these underlying non-communicable diseases. And if you look at the Cox proportional hazards model, we can see that as age advances, the hazard of death advances till over the age of 80. You have 11 times higher hazard of death compared to those who are under 50. The other factors that seem to be important are obesity, dementia, and moderate to severe liver disease. What about TB and HIV? This is a big question, especially for large parts of Africa and Asia. There are emerging reports now from South Africa that suggest that there's a 2 to 2.5 times higher risk of death associated with HIV and TB, but this still needs to be fully disentangled. Those with HIV and TB do tend to be younger, where there's an overall lower risk of death. Now, the role of children in transmission is obviously very, very important, because we have seen that children are they're affected less, they don't get sick, but we don't know whether they can spread the disease to others and how much. And the role of children transmitting is obviously important with respect to school closures. So we looked at all the studies that are out there, looking at the overall susceptibility. So there are studies mainly again from China, very careful household transmission studies were performed by Chinese scientists right at the beginning. And of course, now we're slowly getting reports from other regions as well, but we need more of these good epidemiological studies. And what these show is that the overall risk of children getting infected is about 0.44. So the odds ratio is 0.44, which means that they're 56 or half as likely to get infected as adults if they're exposed to a case. And looking at children as a primary source, again, looking at households where there was an adult as a primary case and the child as a primary case. Again, many of these early studies from China, about 10% of 31 clusters had an index case, but if you included asymptomatic children, then this went up to about 20%. So it's clear that children can transmit, perhaps less than adults, but we need to understand a lot more. It's also clear that the viral load is proportionate to the amount of transmission you can do. So there are individuals, we've seen many descriptions of so-called super spreader events where one individual in a call center or in a pub or in a choir infects hundreds of others. And it's probably a function of many things, including the viral load at that time and including how symptomatic the person is, but also including things like the environment, a closed environment where people are close together, like the bars and the choirs and the religious gatherings or other mass gatherings. It's a combination of factors which leads to these super spreader events. Now, aerosol and surface viability, there's been one good study published which showed that the SARS-CoV-2 virus lasts on copper just for less than half an hour, but it could last on plastic, on stainless steel for longer. Now, if you get aerosolized, and aerosol doesn't happen very often, it happens in situations where there are procedures being done, particularly in hospital settings, and then it could last for about an hour is the half-life of the aerosolized virus. Climate is the other big question, and so far there is absolutely no evidence that either temperature or humidity has a big impact on the transmission of this virus. Everybody was hoping that summer would come and this would go away, but that doesn't seem to be likely. Now, asymptomatic transmission has been in the news quite a lot of late. It's important for public health measures to know how much asymptomatic people can spread the infection. Now, first thing to note is that, again, from pooled estimate of studies, 9 studies from 6 countries, where contacts of confirmed cases were followed, it was found that about 15%, there's a range goes from 5 to almost 80%, depending on the study you look at. But 15 to 20% of infected people can be asymptomatic. And if you look at how much can they spread, so the range of secondary infection from asymptomatic cases was 0 to 2.2 in these 4 studies versus about 1% to 15% for symptomatic transmission. Again, these are limited studies. It's clear asymptomatic can spread. The range you can see is quite variable, but it does appear that asymptomatic people are less likely to spread compared to those who are symptomatic. But this science is evolving, and again, we need better epidemiological studies. So again, people want us to look in the crystal ball and see what's going to happen. Is there going to be a second wave? When is it going to happen? Well, there are many scenarios and possibilities, and we don't quite know what will happen. Again, there are multiple factors. You could have recurrent outbreaks. We're seeing already in Iran, after they lifted the lockdown, there's a second peak, which is as big as the first peak. There are many European countries which are lifting lockdowns. You're seeing slight increases in some countries, not very significant. In other countries, especially in Asia, India, Pakistan, even while the lockdown was in place, the case counts kept increasing. So we haven't yet reached the peak. So you could have peaks and valleys. You could have a big peak in the summer and maybe another peak in the fall or approaching winter. This is when influenza usually peaks. Or you could have what's called a slow burn. It just becomes endemic and it lasts in the population and you keep on having infections. But what we need to do is to prepare for at least 18 to 24 months of significant activity. And we've seen also that the hotspots are across diverse geographies, that it seems to be moving around the world, and different parts of the world are peaking at different time points. Now, this meta-analysis looked at, it's a modeling study actually, not a meta-analysis, a modeling study that looked at 41 countries which had implemented different public health measures, what are called non-pharmaceutical interventions. And what they found was that school closures had the biggest impact, both on cases and on deaths. And again, this is a big question for countries. There's a lot of price to be paid by closing schools. Many children get their only meal in school or a good meal in school. They need both the cognitive and the social interaction. So it's not healthy for a child not to go to school, but what is it going to do to transmission? In this model, anyway, it showed that school closures and then businesses closing down had significant impacts. But of course, these interventions were all implemented in groups. There was no country which did only school or only business closures. And so now that the countries are opening up, need to see like what are the measures that are working successfully. The most important measures are the traditional public health measures of testing of all symptomatic cases. And in places where you cannot do that, then syndromic surveillance may have to be done, isolation of all positives, of course, treatment. And countries which have tested a lot and have tested early have found patients at an earlier stage of the illness and have kept case fatality rates low. Because once somebody is under observation, we know that their silent hypoxia can occur and you can administer oxygen before they go into severe respiratory failure. The other important element here is contact tracing. That's really, I think many countries have struggled with it, including high-income countries, and are now putting in place systems as they lift lockdowns to be able to track contacts. Digital tools are useful, but cannot replace human beings. And so you can use mobile apps and things like that, but by themselves, they do not do the job. Apart from that, of course, there are large-scale public health and social measures that we just talked about on, so-called lockdowns. Lockdown was a term that WHO never used. We used public health and social measures, but lockdowns have become the term now for these really stringent measures, which obviously cannot be sustained for very long. The personal protective measures are very important, ensuring universal masking when physical distancing is not possible, hand hygiene, respiratory etiquette, and particularly as countries are opening up, we need to look at businesses and offices and schools and how they're going to really ensure. So these are the 6 criteria that countries need to look at as they lift lockdowns. First, transmission is controlled. If you have an epidemic that's out of control, that is probably not the best time to lift the measures. Sufficient public health capacity is in place. So the idea of a lockdown is to make sure that you have your contact tracers, you have enough hospital beds, you have oxygen, you have ventilators, etc. Third, that outbreak risks are minimized in special settings. In Canada, for example, 80% of deaths and 50% of cases occurred in nursing homes. We've seen in Europe also that nursing homes, elderly care homes really took a hit. In countries like India, Pakistan, Bangladesh, it's the overcrowded urban settlements and possibly in large parts of Africa. So refugees, migrants, we need to make sure prisons, that these settings, that outbreaks don't happen. Fourth, that preventive measures are in place in workplaces, schools, and others, shops, etc., where people have to go. Importation risks to be managed among travelers, so there should be policies in place. And then very importantly, and often neglected, that communities are fully educated, engaged, and empowered. I'm going to go quickly through diagnostic methods. Everyone knows about viral nucleic acid tests. That's the gold standard to detect viral RNA. The difficulty, of course, is that it's not easily available everywhere. And so what we're really looking for now and working on is a rapid antigen test, which could be used in primary health centers and in doctors' clinics. Now, serological tests tell you about past infection. So the IgG assays are useful because they tell you what percentage of the population has been infected. They can also be used to identify convalescent plasma donors, but again, sensitivity and specificity of the tests vary. And here again, based on the clinical sample that's being collected, the sensitivity of the RT-PCR test can also vary from a low from the upper respiratory tract of 76%, and oral is a bit lower. And if you take lower respiratory secretions, you get higher sensitivity. Now, the chest CTs can be fairly pathognomonic. It's bilateral peripheral ground glass opacities and consolidations. And in some cases where people have done CT scans early on, their CT scan has been found to be abnormal even before the RT-PCR becomes positive. So you see 60 to 90% here in a study in Wuhan had positive lung CTs even before the initial positive. So they were, for some time, Wuhan was using chest CT as a criteria to diagnose and admit patients in the hospital because their lab was not able to keep up. But also, of course, the specificity is low. We know that chest CT findings don't tell you that it is SARS-CoV-2, but it depends on your local epidemiology. So again, early in the course of the illness, it's the virus isolation, and then later on you get your IgM, and then of course IgG, which lasts longer. Just again, a quick point that this does not mean that there is lasting immunity. We know immunity is conferred by neutralizing antibodies, and experience with previous coronaviruses suggests that that immunity lasts only for a few months to up to a year. So we'll have to see with this virus how long immunity actually lasts. I then want to move a little bit to the clinical care pathway, more from the public health point of view, not so much from the individual clinician's point of view. A person should enter the COVID care pathway when they're screened, and it may be different countries are doing it differently. There are drive-in clinics, mobile clinics, there are fever clinics, and then the patient is screened. There's a triage done and a clinical assessment. If they're mild or low risk young person without any comorbidities, they could be sent off to home isolation if indeed it is possible for someone to home isolate themselves. If not, if they're older, if they have comorbidities or they don't have a place to home isolate, then they should be in a quarantine, in an isolation facility where there's also some medical supervision. And again, because of the fact that people can go silently into hypoxia, even those who are home isolating, there should be some way of being able to check on them to make sure that they're not deteriorating. And then they get released from the ward, usually if they have had at least 10 days after symptom onset and 3 days completely asymptomatic. If it's possible, some countries do a viral load test or 2 tests before discharge, but others might go based on symptoms. Now, word on drugs. As such, till today, there are no specific treatments for COVID-19. There have been lots of reports, observational studies mostly, or small case series about chloroquine and hydroxychloroquine with or without azithromycin. The recent results of the recovery trial, which were announced last week, the publication is not out yet, I think conclusively shows that hydroxychloroquine does not offer any benefits, any mortality reduction, and therefore is not of any use in the treatment of patients. Then there are other antiviral drugs which are still under trial. There are immunomodulators, both immune stimulants like interferon and anti-IL-6 modulators, which are used in the later part of the disease when there's a cytokine storm. And then, of course, there's plasma therapy, convalescent plasma therapy, and so on. All of these are under clinical trials. There is, as yet, neither an antiviral nor an immunomodulator nor an immune stimulant that has been shown, and even convalescent plasma, there's been no trial that's reported out. The only drug that's had a report that's come out is remdesivir. The NIAID study showed that remdesivir reduces the length of hospitalization from 15 days to 11 days, but there was no statistically significant mortality difference, though there was a trend towards lower mortality. So we await further clinical trials on remdesivir. Um, Management of mild is only symptomatic. Once there's ARDS, obviously then you need intensive care management. But I think what's important here is for large parts of the world where there are no critical care facilities available, especially in rural areas, that it's really important to be able to monitor oxygenation and to be able to provide oxygen through um, either using a high flow nasal oxygen or if it's possible to use CPAP or BiPAP. That would be the first choice before intubation and mechanical ventilation. So again, I think critical care physicians are learning much more about this disease. Initially, there was a trend towards more ventilation and became clear that actually patients are not doing that well on ventilation. There's also a lot of work now on the pathogenesis of what's happening in the lungs. There's clearly thrombosis happening in addition to the fluid exudation. And therefore, there are also trials now of low dose and high dose heparin that are going on. Management of shock and resuscitation, I'm not going to go in detail. Finally, I'll stop with the last two slides with a word on management of older people with COVID-19. They're the most vulnerable. And I think here, regardless of where they are, whether they're in a nursing home or whether they are seen at a emergency unit or in primary care, one thing to remember is they could present with atypical symptoms like delirium. And it might be worth having an advanced care plan for these people, especially in discussion with the families and with themselves on their priorities and preferences. We need to review the medications to avoid polypharmacy and to prevent medicine interactions and adverse events. And when we had the World Health Assembly last month, there was a resolution that was agreed to by all the 194 member states. And it was good to see that in addition to all of the other elements of care, that palliative care services were actually called out as a separate bullet. And it was said that a multifaceted integrated approach is needed to improving the quality of life, both of adults and pediatric patients, and relief of suffering also should be addressed by early assessment and treatment of physical, psychosocial, and spiritual stressors, relief of dyspnea and other symptoms. And again, with the advanced care plan, if that is identified, then at least we can help those who are going to pass away have a dignified and comfortable end of life. And palliative care is often a very neglected part of healthcare in general, not just for COVID, but for many other diseases. And I think we need to start thinking more about that, and also about rehabilitation, because now the post follow-up studies are showing that many patients are suffering long-term consequences, both in terms of respiratory issues and in terms of fatigue and other, not just coming back to normal very soon. And again, it's not clear why some people seem to have much more long-lasting after effects. And so you might need also rehabilitation services for these people. So I think I'm going to stop there at the first part and then go into research in the second half of the talk. Over to you, Sanjeev.
Thank you, Soumya. That's very helpful, and I encourage the audience to please stay till the second half, which she's going to talk about research and development and access to new COVID technologies. Over to you, Matt.
All right, thank you, Dr. Arora. Thank you, Dr. Swaminathan. Very informative talk. I'm going to relay some of the questions to you that have been coming across in the Q&A box.
Soumya, can you stop sharing? Go ahead, Matt.
We'll go ahead and stop share there so we can all see one another. And the first question comes from A. Sundaramurthy. This is a general question. What do you think is the endpoint for COVID-19?
I wish I had a crystal ball, but what I showed was that we have to be prepared for the next couple of years of living with this virus. We're not quite sure how it's going to behave and what kind of peaks and troughs we're going to see. It depends a lot on what countries do and are able to put in place as well. But we do think that ultimately a vaccine which is available to a large percentage of the population. We know that for herd immunity, you need for this for a virus which has an R0 or R0 of 2 or above, you need at least 50 to 60% of the population to be immune. And therefore, you will need to vaccinate a very large number of people. And so that may take 12 to 18 months is a very optimistic timeline for a vaccine. And then it has to be produced in billions of doses. And so I think we're looking at the next 2 years at least of solid public health measures in trying to control this.
Swami, let me just add one thing to this question about this. As you mentioned, the coronaviruses are they often don't give long-lasting immunity. And at least there seems to be a narrative roaming around right now in the world that you'll get the vaccine and then you'll be protected for life. What is the mechanism that people would believe that a vaccine would give long-lasting immunity when COVID-19 alone may not? And is this sort of you see this as an annual vaccine type of deal?
So this is again a very important question which we don't have an answer to, because first of all, we don't know how long natural immunity will last, and that might determine. The good thing, what we know is that most people who recover develop antibodies, and they do develop neutralizing antibodies. Though again, the level of neutralizing antibodies seems to be depend also on the severity of infection. So we're optimistic a vaccine can be produced. But how long the vaccine immunity will last, we don't know. It's possible that like the flu vaccine, you need it every year. We also don't know how the virus is going to behave in terms of mutations and whether it, so far it's unlike the flu vaccine, unlike the flu virus, it is not mutating as rapidly, and certainly not in the key elements like the spike protein. So that again, till now is good news.
Thank you, Matt.
Thank you. The next question is from Sri Lanka. This is from Rajanthi Ramachandran. So Dr. Swaminathan, you had commented on asymptomatic transmission. Asymptomatic patients contributed to more than 60% of cases found through contact tracing in Sri Lanka. I wonder if you can speak to the public health implications.
Yes. So I think you need to follow up these people to really say they were asymptomatic. And what we've observed is that in studies which have really followed up these people, at the time of detection, they're asymptomatic, yes, but in a couple of days from then, they may actually develop some symptoms. Could be mild, but they develop some symptoms. So you would then classify them as pre-symptomatic. It could be just an academic, you could say that it doesn't matter, but I think it matters because they're not completely asymptomatic for that period of time. But yes, if you do good contact screening and test a lot of people, you're likely to find quite a lot of asymptomatic individuals. In fact, in China, currently, most of the people they're finding are asymptomatic. So I think as your case detection, contact tracing, and tracking improves, then that ratio actually begins to change. So it also reflects that you're doing a good job of detecting of tracking your contacts and testing them.
Okay, thank you. The next question is from Yogesh K. What is your opinion on reopening schools and universities? Some studies from the National Institutes of Mental Health and Neuroscience say that online education affects the children's mental health. So what can the schools do?
Well, I think we, as I showed some data, we're learning a little bit more about children and their role in transmission. Some countries have opened schools. I think we'll have to wait and see. It's very difficult for young children to maintain any kind of physical distancing. It's maybe easier for the older children. And one has to open the schools and universities knowing that you may need to go in and do cluster investigations. I think what happened in South Korea was they opened schools. Within a week or 10 days, they had in 1 or 2 schools, I mean, if one person gets an infection, a teacher, let's say, it's likely to spread. So you need to then go in and be able to really track and test everybody in that cluster. So this is the period of preparation that countries need to use for the time when they open up. So of course, children need to go to school. Online learning in many countries doesn't work because there's no access to internet, etc. And as I said, especially in the poorer countries, children also need to be out of their homes. There's a lot of violence, domestic abuse, etc. going on. We've seen that violence against children, against women has really increased in these last few months of lockdowns. So there are lots of negative effects from not opening schools and colleges. But then you need to put in place, hand washing stations, practice physical distancing as much as possible, really teach the children. And then, as I said, have a high degree of suspicion to go in and test and be able to isolate. People who are unwell shouldn't be asked, should be told to stay at home and not come to school, etc.
Thank you, Dr. Swaminathan. Over to you, Dr. Arora.
Well, yeah, Swamya, there's still a lot of questions about this vaccine. Dr. Azim, Dr. Warren from USA, Dr. Kumud Rai from India. We have Dr. Nguyen from Vietnam, and others from many, many other countries. Talking about this issue of time frame of the vaccine, you mentioned 12 to 18 months. There's a narrative, at least in the US, that there's a vaccine could be available by September of this year. The other issue, of course, is this issue of availability. I mean, you talked about 6 billion doses. How will they be produced? How long will that take? And also, what is WHO's plans to make sure that low-income countries also have the opportunity so that this doesn't become a rich person's vaccine? And how fast will that happen for low and middle income countries?
Can I take that in my next section?
Sure.
Because I'm going to talk about this.
All right, that's great. Can you also tell us about this balance between the economy and the health? Because there is a narrative about the issue that the economic harm done from these lockdowns significantly exceeds, that is, the number of deaths, the human suffering is much greater by doing that than by just sort of opening it up and let herd immunity develop. Because lots of countries, as you know, they don't have an appropriate social security system, and they are working on daily wages, and they don't have the reserve currency that the US have, that they can just print and not a limitless amount of money to give the purchasing power to these people. So could you comment on that?
This is indeed a very, very difficult situation and a decision, and I wouldn't like to be in the shoes of the political leaders who have to make these calls. Incredibly difficult, even more so if you're in a low or low middle income country where so many people in the informal sector depend on their daily wages to eat. So every country has to find a balance and look at COVID as something that's going to be around for some time. At the beginning, when the first few cases come in, many countries have taken strong measures to keep it in check and to not let it spread. And that has helped them. And some countries in Africa have been able to do that. And we've seen Southeast Asia also, countries that have managed to keep it down to a very, very low level. In many of these places, the testing capacity was ramped up very quickly. And of course, we are limited again because we are using RT-PCR. The moment we are able to switch to simpler methods of testing, I think it would help. You need a public health workforce to be able to basically go and find those who are symptomatic, who are infected, and isolate them, and also be able to quarantine the contacts. That is probably the most effective way of keeping this in check. And for that, you need many different elements. You need good governance, you need tracking systems, you need to be following your data, and you need a public that cooperates with you and that follows the measures that the government is asking you to do. But again, You have areas, urban slums, etc., where you may not have good sanitation facilities, but even in those areas with those limitations, some cities have been able to show that you put in hand washing stations, you provide facilities for the residents, you take them away and quarantine them in facilities which are humane, compassionate, respectful, and basically you have to motivate people to come forward for testing, because if it's like a punishment, then people are not going to come forward. So I think we have to find low cost options. And again, there was a mad rush to buy ventilators in the beginning. And we know that once you're on a ventilator, your prognosis is poor. You need a huge team, etc., to support you in the critical care unit. But oxygen itself is not available in many countries at the primary and secondary level. So investing in oxygen, trying to keep mortality rates low, um, the demographic in Africa and South Asia, I think, is advantageous because many people ask, why is the mortality lower in these countries? So it could be to a large extent the demographic of having younger populations, but then you have other comorbidities, you have malnutrition, you could have HIV, TB, etc. We'll have to see how those play out. So there's no simple answer, Sanjeev, but the point is, till we have a vaccine, it's only the public health measures that need to be implemented well to keep it under check, while at the same time also making sure that essential health services are being run, because we don't want a situation where there are more deaths due to malaria or TB or vaccine preventable diseases, because immunization has taken a hit. So you might end up with measles outbreaks and other kinds of outbreaks. That also needs to be kept going. So you need investment in the health workforce as well.
So Soumya, last question before you go back to your talk is this issue of the second wave. You mentioned that there was no data about weather and temperature, etc., affecting, but of course there's a counterbalancing narrative about in the fall and when winter comes, and we do know that coronaviruses, spread a little bit more, the common cold virus in the winter. There's more sniffling going around, and so could you just comment a little bit on this and what are your thoughts about, is winter in these countries going to accelerate issues or not really?
Yes, we believe that winter could make things worse, not necessarily because a virus is doing better in cold climates and so on, but because human behavior changes with the climate. In the summer months, you tend to be more of outdoors and keep things open. There's better ventilation, etc. In the winter, especially in the northern hemisphere, you'll find that things close down. People tend to stay more indoors and there may be more crowding. Now we'll see what happens in the southern hemisphere now that they're going into winter. So again, it could be related more to human behavior than to the virus's behavior. It's also true that the influenza season also peaks in the winter, and that will be a huge strain on the health system. This year, in a way, we were lucky because in the northern hemisphere, when COVID was going up in North America and Europe, it was the influenza was actually declining in March. And so you could see that, and in fact, the physical distancing measures that were put in place in many countries showed a sharp decline in influenza cases. And so it was clear that it was also acting against influenza transmission. So if the two coincide, influenza and COVID-2, in the winter, that's going to be very difficult for health systems to handle.
So is the virus morphing with time? I hear that there's a European, which is a little bit different from the Chinese virus, and does different viruses have different mortality? And what's the evolution of this?
So it's an RNA virus. It mutates like all viruses, and the databases now have more than 40 or 45,000 strains from different parts of the world, the public databases like GISAID and GenBank. And the analysis has been, the scientists who are analyzing these have divided them into different clades based on certain polymorphisms. Now, so far there is no correlation between the strain or the clade of the virus and clinical manifestation or severity. So these have been more useful to actually study transmission patterns. So for example, Washington State got the virus from China at the beginning of January, and the East Coast got the virus from Europe. And that was possible to say because of the differences in the sequences of the virus. So it's useful to track. In fact, the new outbreak in China, we're still waiting for the final results, but they say the clade is different from the original outbreak. So perhaps it's come in through travelers, returning citizens. So it's useful for that. And it's also useful to keep track of whether there are significant mutations on the receptor binding domain of the spike protein, which is actually the site for drugs and viruses to act. And if that mutates, then it's going to be a problem for vaccine development. But so far, there haven't been any such critical mutations.
Over to you, Matt.
All right, thank you. I want to thank everyone for these questions. And Dr. Swaminathan, we will transition back to you for the research aspects. And just a reminder to our participants that we will have another moderated Q&A leading up to the 30 minutes after the hour. So take it away, Dr. Swaminathan.
You see my screen?
We
Yes.
can.
So if we go into R&D, and there was a question on access and when will vaccines be available. So we launched something called the Access to COVID-19 Tools Accelerator, the ACT-A, which was a group of global health actors who came together, of course, led by WHO, to develop a partnership that would help to develop these tools. And the first objective really is the aim of equitable global access to all of these tools, partnership, a strong unified voice, building on past experiences, be accountable to the world, to communities, and to one another. And it shows all the initial partners, many countries, the Global Fund, CEPI, Gavi, UNITAID, as well as the Developing Country Manufacturers Association, the International Pharmaceutical Manufacturers Association, the Gates Foundation, etc. Now, this was launched on the 24th of April with many world leaders, including President Ursula von der Leyen from the European Commission. And on the 4th of May, she launched a pledging event, which has so far raised about $9 or $10 billion for the development of these tools. Now, the goals really are to end the COVID-19 pandemic, to restore full societal and economic activity globally, and to facilitate the high-level control of COVID-19 disease in the medium term. So medium-term goals and longer-term goals. There are three pillars. There's the delivery, the partners group or the facilitation group. There's a vaccines pillar, a therapeutics pillar, a diagnostics pillar, and a cross-cutting health systems pillar. And each of these pillars is led by 2 or 3 of these organizations that I mentioned. And the way WHO works is really cutting across all of these pillars, because we are responsible for some of the elements of the R&D, like setting the target product profiles, defining what needs to happen in the R&D space, of course, contributing to policy development. That is very much WHO's role, working on a fair allocation framework, and of course, on the regulatory side, we work on with the regulatory agencies from around the world to try and harmonize the regulatory processes and also do pre-qualification of vaccines, drugs, and diagnostics. Now, early in the pandemic, we organized a big global research and innovation forum in Geneva, where we had about 350 people participating in person and many others virtually, to assess the level of knowledge about this new virus, agree on critical research questions, define ways to work together to accelerate. And we had a number of funders as well attending this global forum. This came out with a research roadmap that you can find on our website, which had clearly defined priorities and a governance framework. And it led to a set of key actions that were considered really high priority at that time. So rapid point of care diagnostics was considered a high priority area for research. What are the standard approaches which could make patients in terms of clinical management, evaluate the effect of adjunctive supportive therapies, optimize the use of protective equipment and other infection prevention and control measures, things like masks, how do they work, hand washing, other protective mechanisms. Then there was a whole area of work on identifying the animal hosts to prevent continued spillover and to better understand the virus, its transmissibility, and who's more susceptible. Accelerate the evaluation of therapeutics and vaccines, again engaging with funders so that they're aligned as well, and then broadly and rapidly share virus materials, clinical samples, and data. And the elements of the global research roadmap was that there are clearly set priorities. We hope that leads to national research plans and agendas, a coordinated implementation of critical research like using core generic protocols. And as an example, we developed a set of protocols that was made available through our website on how do you go and what we call the first few cases, FFX protocol, the first few cases in a country. How do you investigate those? A household transmission protocol, a healthcare workers risk factor protocol. Then we had the Solidarity trial, therapeutics. Solidarity 2 looks at seroepidemiological studies. We have engaged developers and manufacturers right from the beginning. The private sector has been part of all of these discussions. And of course, now we're looking at scaling up manufacturing. That's part of the vaccines work that we're doing. Now, we launched also fairly early the Solidarity protocol to look at treatments and basically to look at the effects of these treatments on in-hospital mortality as well as on the duration of hospital stay and the need for ventilation. Now, this trial is in adults over the age of 18 years who are hospitalized, and they are, it's a very simple, simply designed trial. It's all electronic. There's no paperwork at all. There are 5 arms, the standard of care arm, remdesivir, which is an antiviral developed by Gilead, tested for Ebola, was not found to be very effective, and it was shown to have in vitro activity against SARS-CoV-2. Lopinavir, ritonavir, which is obviously a combination used to treat HIV, with interferon beta 1b, which is an immune stimulant, antiviral action, and then keeping the and then hydroxychloroquine was also later added as a 5th arm in a high dose. Now, study enrollment is via a centralized website. There's a global centralized randomization. All the doctor has to do, so even a busy doctor in a hospital just enters their ID. They're each given an ID, obtain consent, then enter the registration information with a few details about the patient, proceed with randomization, initiate administration. We send the drugs to the participating hospitals, and at the end, we only ask about these things: provision of ventilation, duration of hospital stay, and mortality. It's an adaptive trial design, which means you can add arms and drop arms for non-efficacy, etc. The governance is we have a global steering committee that's made up of 9 or 10 experts from these different participating countries, and also a global data safety monitoring committee that looks at the data. So investigators are all blind to the outcomes. The DSMC has access, and then they report back to the steering committee. So currently we have about 20 countries enrolling. It started in Europe, so the blues in France, then it picked up in Iran during the outbreak, and now other countries like India, Indonesia, Philippines, Malaysia, and many others. In fact, we have countries in all continents who are enrolling. The idea really is that as we test some therapeutics and decide whether they are safe or not, or efficacious or not, you can add more. So if monoclonal antibodies are going to be the next promising treatments, one could add those also, because the trial sites are all set up and running. And the advantage is, of course, that you can enroll quickly, you can enroll large numbers. Currently, we are, I think, at about 4,500 people, so probably the second largest trial in the world after the recovery trial in the UK, but we continue to enroll. Now, quickly moving to vaccines, we started working on vaccine development also very early on. And partly this was helped by people who had worked on SARS-1 and MERS viruses and even developed vaccine candidates and platforms. So we knew that you need to focus on what we called enabling sciences, animal models, because it's a new disease. You need standardization of laboratory assays and reagents. You need to look at cross-reactivity with the other coronaviruses. So we set up working groups to look at all of these, and also a working group that would periodically look at the landscape of vaccine candidates and be able to prioritize based on some of the criteria. So there was also a group that developed criteria for vaccine prioritization, a group that developed a clinical trial protocol. We know that this moves like this through preclinical animal phase 1, 2, and then into 2, 3. Then there's licensure. Sometimes it's an emergency use license, and then followed by a full licensure. And then we have what's called the SAGE, the Strategic Advisory Group on Immunizations, which makes policy on vaccination and immunization. So all of this normally takes 5 to 10 years. That's the normal vaccine development timeline. I think the shortest it's taken for a vaccine is 2 years for the Zika vaccine, and by then there was no need for it. For Ebola, it took about 5 years to really test the vaccine and find out that it's for the Merck vaccine. The J&J vaccine is still undergoing clinical testing. So here the goal was to reduce that timeline to 12 to 18 months, but without compromising on the basic principles of trials. So safety is very important. And one of the concerns that's been raised is an antibody-dependent enhancement of disease, which has been seen with vaccines like dengue vaccines in the past. So it's important to go through all of this, but the way you reduce the timelines is by compressing and also by investing in manufacturing even prior to the results of the trial. So for example, AstraZeneca says they'll have hundreds of millions of doses by the end of the year, and that's because they're already, either they or somebody who's given them funding. So they've got funding from the US, from the UK, from CEPI, etc., from the European Union, investing in manufacturing capacity so that if the trial results come out, and they're going into phase 3 trial shortly, if the trial results are successful, they would be able to ramp up manufacturing to hundreds of millions of doses. But if the trial is unsuccessful, then it's a waste, and that manufacturing capacity will have to be turned to something else. But so that's what it means when you do something at risk. You invest at risk. You're not putting people at risk. So sometimes the public may think that at-risk development of vaccines means that they're going to be at risk. It's not that. It's manufacturing investments which are being made at risk, and also by working very closely together with regulators, with clinical trialists, etc. So we are closely in touch with the group in the US, the NIH, that's working on a set of vaccine candidates so that we align, we collaborate, we coordinate, particularly on things like endpoints and clinical trial design. We know currently that there are 10 vaccine candidates in clinical development, but over 200 and from all parts of the world. So many candidates being developed. Now the 3 that have gone into phase 2 are the Chadox vaccine. That's the one where the University of Oxford developed it, and it's with AstraZeneca now for further development. They are going to start phase 3 very soon. Of course, in the UK, where they're doing their phase 2, they don't have a lot of infection anymore, so they may not have endpoints. They're now moving to other countries as well, the US, Brazil, Kenya, South Africa, to test this vaccine. This is a chimp adenovirus, and the preliminary results show that it does not eliminate the chimpanzees from, or the primates from getting infection, but it seems to prevent them from developing pneumonia and severe disease. So again, that's another property of the virus. Is it going to cut transmission, or is it only going to reduce the severity of the disease? Then you have the virus, the vaccine from China, the CanSino Biologics. It's again an Ad5 virus. It needs 2 doses. Potentially, they're also tying up now with many countries to go into phase 3 trials. And then you have the Moderna, which is an RNA vaccine was the first one to go into phase 1 trial. They went in March itself into phase 1, finishing up phase 2, will go into phase 3. But again, we haven't seen results from any of these trials except for some press releases. So if the WHO would propose a solidarity vaccine trial, this would be solidarity 3, because I mentioned 1 and 2. The idea would be to try to evaluate as many candidates as possible in a prompt and efficient and reliable way to make sure that you get as many as possible into testing, and at least some of them will then be hopefully be successful. As compared with doing multiple different trials, which are sometimes small and not conclusive, a large multi-country parallel arm trial would increase the likelihood, first of all, that participants would receive one or the other of the vaccines. It would reduce uncertainties in endpoint acquisitions, because you could go to countries where there is ongoing transmission, and it would more rapidly identify the most successful vaccines rather than going one at a time. And so it will be speedier probably. And of course, it increases the consistency of the evaluation process, because you're using the same methods, the same endpoints, the same clinical case definitions, and the same laboratory assays. You could still do this by having everyone agreeing on a standardized protocol, everyone agreeing on the lab assays and standardizing them, and having trial sites in multiple countries, which could have different sponsors as well. So the primary endpoint for a trial, for a vaccine trial, would be virologically confirmed disease, and then you could have multiple secondary and additional endpoints. And we also have a series of studies called Solidarity 2, which is basically on seroepidemiological studies. Currently, there are over 90 that we know of which are underway. Some of them are published, some of them are come out in press reports, etc. There's a huge variety of populations that have been studied. Different ELISAs have been used. But most results that we've seen so far suggest that less than 10% of the population has evidence of SARS-CoV-2 antibodies. Some exceptions like New York, over 20%, London, close to 20%, but Spain, Italy, Germany, all in the range of 5 to 7%, and even Stockholm, where they expected to have a higher prevalence of antibodies because they did not do stringent lockdown, had only 7 to 8%. So this is useful, of course, but it also shows you that the majority of people are still susceptible, even in those countries which had these huge waves. Lastly, I just want to mention about essential health services. We did a survey recently where many countries took part. Obviously, we know that there's a huge stress that has been imposed on health services and healthcare workers. And when we did this rapid survey of about 11 questions, the results showed that about half the countries had a defined set of core essential services. So only half even had those list of essential services which need to be maintained during the COVID-19 outbreak. And only about 38% had allocated additional funding to maintain those services. And many countries had limited or suspended some service delivery platforms like mobile clinics, outpatient services, inpatient services, emergency unit services. And of the services that were disrupted, routine immunization was disrupted. In the red is complete disruption and the yellow is partial disruption. So you can see that immunization services, almost 80% of countries were disrupted. Also dental services, rehabilitation, ITN campaigns. So one expects that malaria may go up, NCD diagnosis, and so on and so forth. Emergency surgery, even emergency surgery was disrupted. Sick child and malnutrition services and all of these. So really it's important that provision of PPE is obviously very important to keep the healthcare workers safe. Capacity building is needed. in order for health workers to be able to manage both COVID and other services. You need an integrated tool for monitoring of trends and key indicators. I think that's not really happening. Many countries found that their non-COVID mortality went up also at the same time. But those are all high-income countries which have good mortality reporting. We don't know what is happening in many countries which do not have that kind of real-time mortality reporting. We may find out many months later the impact. Sharing of experiences, telemedicine strategies is really important. I think ECHO is a good platform that's really being used now for capacity building and training, but potentially could also be used to provide medical services to patients. So there's a report on our website. And finally, I think I would like to end by saying that there's still a lot of unknowns, though we've learned a lot in the last few months. A lot will depend on whether we show global solidarity or whether countries decide to go individually, whether we follow science and data. There's a huge infodemic, as we call it. We coined the term infodemic to describe all of these myths and rumors and false information that was being put out. We need acceleration in R&D with collaboration between private and public sectors, equitable access to whatever is developed, very, very important. We need to continue to use the tried and tested public health measures till we have these new tools. We're getting better with drugs, we're getting better with treatment, with diagnostics. Let's capitalize on those things till we get the vaccine. Public engagement education is really, really key. Again, we talked about how to minimize economic impact, how to protect the most vulnerable, because they are the ones who are going to take the hardest hit. And of course, countries need to balance the social and economic needs with containing and mitigating COVID. It's a delicate balance, but there are countries which have shown that it is possible. And so it should be possible, I think, if collectively the right things are done. Thank you, Matt. Back to you.
All right, thank you, Dr. Swaminathan, for sharing these updates. A couple more questions. This is a question from Prashant Kirkar. How have countries like New Zealand declared themselves COVID-free? Can you comment on that?
Well, because in a way it was easier. I think an island, it's a small population of 5 million people, and they were able to do exactly what we have been describing, of being able to find all the cases and to isolate them and to make sure the contacts are tracked and don't get disease. So over a period of time, they were able to eliminate, and they closed all travel. So there were no new imported cases, and they were able to clear the infection. Now this is a unique situation, but similar things have been done in other countries. Taiwan has done it, again, an island, of course. You have South Korea, you have Singapore, which was very effective, and then found cases increasing in their migrant workers' dormitories. You also have countries in Africa, like Rwanda, like Senegal, which have done a great job. So you have many examples, I think, of countries which have done the right thing.
Thank you. And then on the flip side, this is a question from Roberta Pinto Graber. What is the perspective of the World Health Organization for Brazil as we are easing the rules of isolation in the midst of the pandemic with growing cases and mortality and without mass testing?
I think this is what happens in countries which are not, implementing those measures that we talked about. It needs both government interventions and community and individual interventions. And so I think very sadly, we're seeing the results of what can happen when the spread sort of goes out of control.
Thank you, Dr. Swaminathan. Sanjeev, back to you.
Yeah, Soumya, so you pointed out, that you need global solidarity. And we know that this virus does not respect national boundaries. Whereas, at least from the perspective, what I'm seeing in the world is most countries are mounting a national response versus a global response. Yeah. So now you have a virus that doesn't respect these boundaries. And the responses of the world are all national responses. My country, unless we are going to build walls around each country to prevent any transmission in the future, we do need to somehow organize ourselves more globally. What mechanisms does the United Nations, if it's not the WHO or other multilaterals, have for this kind of a global response, where there's a much more coordinated action across the world as opposed to each country doing its own thing?
So Sanjeev, I think you've hit the nail on the head. It needs political leadership and determination. It's, as the DG keeps saying, Dr. Tedros, it's entirely political. There is no other way. And we've seen that countries have come together. If you look at the United Nations General Assembly resolution that came out about 6 weeks ago, it talked about solidarity. It talked about developing tools for global access, for equitable access, for countries to work together and to support the UN and other multilateral organizations. But then every country also does have to think about its own citizens. So that's, again, I think a balance where the political leadership of a country definitely needs to show that they're protecting their own population. But at the same time, it's clear that you cannot live in a bubble. You can't live if all around you things are out of control. And so I think this is being discussed and will continue to be discussed. But it's really, I think, a test for the global leaders to come together. We know that they're discussing it in G7 and G20 and so on. We had our virtual World Health Assembly in May, and I brought one of the resolutions from there to show you that they wanted this equitable access, and they came up with about 33 resolutions actually, which spoke to what countries should do, that's member states, what WHO should do, and what the UN system should do to deal with this pandemic. So the intentions are all there. Now they have to be put into practice. And the vaccine, I think, is a very good test of whether everyone is willing to abide by these principles that have been articulated.
Thank you, Soumya. Let me get back to the science. I think the issue of antibody testing, the data that I look at show such a wide variation in the antibody tests, at least available in the United States, with inaccurate results and ranging from 2 to 30%. And I think the challenge that I see with this test is, could it not just lead to making the wrong decisions and do more harm than good by having an inaccurate test? And then along with that, the antibody, then the issue comes is this issue of, instead of the vaccine, just giving antibodies as treatment, whether it be convalescent plasma or monoclonal antibody. Could you just comment a little bit on that?
Yeah. So there are several elements to your question. The first one, of course, is the quality of the test. If you have a useless antibody test, then it tells you nothing. You might as well throw it away. So we have an agreement with this public-private partnership, the PDP, called FIND. We're working closely with them. And as you know, there's a diagnostics pillar now, the ACT Accelerator. The number one priority is to develop a rapid antigen detection test, which is highly sensitive and specific, because that in the hands of a healthcare worker would really change things. But antibody tests, so the first thing is to make sure that these are validated and quality assured. Secondly, how do you interpret them? You cannot use it to make a diagnosis. You could use it at the population level to see how much your infection rate has spread in the population, as many countries are doing now, and to understand what happens over a period of time. You can repeat these surveys. So Geneva City has been doing surveys every 2 weeks to see, and it went from 5% to 8% to 10%, and now it's stabilized at 10%. You cannot use it at the moment as an immunity passport, which has been suggested by some people as a way of people to say, I'm immune, I've got antibodies, I can take risky jobs. Perhaps but we don't know as yet. First of all, how well protected you are, and secondly, how long that will last. So using it as an immunity passport right now, given the current knowledge of science, is not possible. And there are lots of ethical debates that are happening around whether it's good or bad. But scientifically, right now, we would not recommend that anyone uses an immunity passport. But you could use it to find donors for, say, convalescent plasma therapy, or if you want to make hyperimmune globulin, then you could use it. So there are uses for the test, but there are many caveats and limitations which people must understand before this test is widely used or interpreted.
The convalescent plasma and monoclonal antibody treatments.
So convalescent plasma has been used. It's a age-old treatment. It's been used from the previous centuries, but we don't know whether it'll work. There are trials going on. I think we should wait. It didn't work for Ebola, even though it was expected to. So let's wait and see. I'm more hopeful about monoclonal antibodies. Again, for Ebola, when the trial was done, it was eventually monoclonal antibody and a cocktail of monoclonals. There were two that were shown to work. So it's possible that either a single or a cocktail of monoclonals could work. And the exciting thing about monoclonals is that it could also be used for prevention. If you had a long-acting platform and you could deliver monoclonal antibodies to someone, they could stay protected for a couple of months, let's say. So that might be quite useful before we have a vaccine, if we could use that. On the other hand, there are issues of scalability and manufacturing, and especially in the lower income countries. And that aspect would need to be addressed if indeed this is going to be a treatment that's widely available. So we know that there are several companies, a dozen or more, working on monoclonals. The first few are going into clinical testing now. And so later in the summer, we should have some results. But that's one of the treatments we might include in the Solidarity trial if we had some promising monoclonals.
Thank you, Soumya. Over to you, Matt.
Right, thank you, Sanjeev. One more question for you, Dr. Swaminathan. This is a question from Mira Parikh. How will the impacts of COVID inform pandemic preparedness efforts in the future?
Pardon?
I'm sorry, how will the impacts of COVID inform pandemic preparedness efforts in the future?
Yes. So again, this is a hypothetical question at the moment. Right now, we're dealing with this pandemic, and we have to come out of it. But many people, including the WHO, had been warning that something like this could happen and would happen at some point. Perhaps a lot of people thought it would be a flu pandemic because, all the previous pandemics, anything that's been called a pandemic in the past has been an influenza virus. This is the first non-influenza pandemic, but it was predicted that it would be a respiratory virus, could be flu, that it would come from a zoonotic source, that it could be rapidly transmitted human to human, and that it could have big impacts on mortality. However, most countries didn't take it very seriously and did not prepare. This is across the board, from high income to low income countries. And also what we've seen happening in global health is cycles of panic and neglect. So when Ebola happened, there was panic. This is the West Africa Ebola I'm talking about. A huge amount of resources were thrown into the epidemic, from preventing it from really growing and spreading. But then there was neglect subsequently in public health. And so I think the lesson really here is that another pandemic will happen at some time in the future. This is bound to happen. And so we really need to prepare our health systems, all the different elements, from building surveillance capacities, having the field epidemiology training, having good data information collection systems, health information systems, obviously having good primary health care, having a health workforce that's trained and also capacity to quickly scale up if needed in this kind of situation, using digital tools and technologies to complement traditional, and then building the capacity, obviously, of also secondary and tertiary. But I think what gets neglected is usually primary health care. So with prevention built into it, and really primary health care in all its components, which includes the building of the relationships with community. And I see that somebody has commented on the community response in Brazil, and I do agree that communities which are well informed, sometimes do take actions even if governments are not, and can play a big role in pressurizing governments also to act, both at the local level, at the national level. So I think those are the kind of investments that are needed. They have to be sustained, and they are not very sexy, they are not very visible. And if you avoid outbreaks, nobody gives you credit. But the moment you have an outbreak, then of course everybody blames you. So it's an investment that you cannot get a lot of brownie points for, because it's not visible, like building a bridge or a road or a hospital, which is visible to the public. And that's why it's so tough to prioritize this over other things. But hopefully that's a lesson that we will learn now.
Wonderful. Thank you, Dr. Swaminathan. That brings us to the end of today's session. And to conclude, we'd like to thank Dr. Swaminathan for her time and her expertise today. And thanks to everyone on the network for attending this first in our series, ECHO COVID-19 Global Conversations. We hope to see you on Monday, the 22nd at the same time for Cardiac and Vascular Manifestations of COVID-19, presented by Dr. Ranjit Suri, who is Director of Cardiac Electrophysiology at Mount Sinai. And please look to the chat box. You're going to find a CME link there that's available, and this will also be included in the follow-up email that you'll receive today. Please also watch for announcements in our ongoing Global Conversation series and save those dates. And visit our ECHO COVID-19 Global Conversations webpage for session updates and information. The link will be available in the chat box for that as well. And thank you again for your continued interest in Project ECHO special programming on COVID-19, and we hope to see you all on next Monday, the 22nd. Thank you. Bye.